Hello, I'm Dr. Phillip Myers from Nexus Eye Care, and today we're going to be talking about glaucoma. And to do that, I've got our glaucoma expert with us today, Dr. Rohan Gupta. Hello, Rohan.
G'day, Phil. Thanks for having me.
Pleasure. Glaucoma, often called the sneak thief of sight, because it can creep up on people. It can worry people a lot because once lost forever, our vision in glaucoma. And many people have a great fear of glaucoma because they've had an elderly relative perhaps, or someone in the family, someone they knew who was really disabled by this condition. So to be told that you've got glaucoma in a consultation, often the brain just clouds over, and if you've been told that, you can't hear what the doctor's saying. So now's a good opportunity for us to ask you some questions. So Rohan, in simple terms, what is glaucoma?
Okay. Really good question. Really important question. And one that confuses a lot of patients. Glaucoma simply is a loss or damage to your optic nerve. So the way I usually explain it to my patients, if you look at the eye here, and we have the eye in cross-section, if you think of it like a camera, you've got the lens at the front, that will later become your cataract. Then you've got the film in the camera, that's your retina, and then you have the optic nerve. That's the cable from the eye to the brain or from the camera to the computer. The optic nerve is not one singular nerve. It's made up of about 1 million fibers, and they map out the world as we see it. When we have glaucoma, we start to lose these nerve fibers. So you start with 1 million, and you could lose 20, 30, 40,000 a year. And over 10 or 20 years, you have no nerve fibers left. That's what glaucoma is, and you can think of it as each nerve fiber maps out an individual pixel in your visual field. As we have worsening glaucoma, individual pixels start to disappear off your field of view.
So I would imagine a person would pick up glaucoma very easily and very early if it's affecting the middle of their vision. Is that the case in glaucoma?
Yeah, unfortunately, that's not how glaucoma works, and it tends to rob us of our peripheral vision first. So it's very hard to detect for the average person until it's quite late. Central vision is preserved until the very end. Again, like I explained to my patients, it causes a tunnel vision, and as glaucoma gets worse, it's like looking through a toilet paper roll, and it gets smaller and smaller and smaller until you eventually run out of central vision.
So if a patient is losing peripheral vision, would they be aware of it at an early stage? Would they be bumping their head on a cupboard or not seeing lane traffic early on?
Look, sometimes it can present that way. Usually it's more advanced. By the time you get to the stage where you're bumping into things or have neglect on one side or the other because of your glaucoma, the disease has progressed. We like to catch it a lot earlier and treat it or start managing it a lot earlier than that.
So in fact, you can have glaucoma without any symptoms whatsoever of loss of field of vision.
Yes, that's correct. And we've made tremendous strides in the past 20 or 30 years with screening, and the optometrists have been invaluable in this because when you go into your optometrist to get your glasses, they'll often do a visual field test as a screening tool, the same way we screen for prostate cancer or diabetes or cholesterol. We now screen for glaucoma. We catch it early so that we can start treatment early.
Are some people more at risk of getting glaucoma? If we're talking about screening, should some patients be more aware to get screening tests than others?
Yeah, absolutely. There's certainly risk factors. Genetics is one of the biggest ones. So if you have a family member affected by glaucoma, really important to get screened regularly. Patients who are short-sighted are often more at risk of developing open-angle glaucoma, as well as age. With a lot of things, it's there in our genetics, but it doesn't come out until we get older. So just because you don't have glaucoma at 40 doesn't mean that you can't develop it at 50 or 60 or 70.
So Rohan's just explained to us that screening is important to detect early glaucoma. But we also detect glaucoma when we're seeing our patients for other conditions such as cataract or dry eye or macular degeneration. And we can do tests that will screen and pick up glaucoma in our office. How do we know a person has glaucoma if they have no symptoms?
So this is actually one of the biggest issues that we have, and it's one of the hardest or biggest challenges as a glaucoma surgeon, that patients will come in and say, "Doc, I have no symptoms. I don't think I have a problem." We do the screening test and we check your peripheral vision, and we can see that there is vision loss. We take photos of your optic nerve, and we can see that there is damage to the optic nerve, and it all correlates with that loss of nerve fibre.
So when you say we can check a person's visual field, is that the visual field test that people are subjected to?
Yes, that is the visual field test. One of the hardest things with glaucoma is convincing someone that treatment is an option, that it should be taken up, because patients often don't realise they have a problem. The treatments can unfortunately make dry eye worse. But again, the way I explain it to my patients is, if you're diagnosed at 60 with glaucoma and you were going to go blind at 90, the aim of treatment is to slow down that rate of loss so that your blindness is pushed back till you turn 120 or 150.
So visual field testing is important, but we can pick up glaucoma using even more sensitive equipment in the clinic. What do we do for that?
So in the clinic we have OCT machines.
What's an OCT?
So it is a machine that uses an infrared light to take a measurement of the optic nerve. So it measures how much nerve tissue is at the back of the eye and if there is any thinning of that nerve tissue, and it measures it to the micron.
So of all the 1 million nerve fibres exiting the back of the eye forming the optic nerve, we're able to pick up subtle losses of nerve fibre, perhaps even before that loss is shown up as visual field loss.
Yeah, absolutely.
So getting a diagnosis early is really important. Once we've established the diagnosis, I guess the aim of treatment and everything is to stop progression.
That's correct.
So let's get on to treatment. What are our treatment options in one of your patients with glaucoma?
So the first thing to recognise is that glaucoma is not reversible. The damage that has occurred can't be undone. The aim of treatment is to slow down the disease, and the way we do that is by lowering the pressure within the eye. We have 3 basic ways of lowering pressure inside the eye: drops, laser and surgery. Surgery is always option number 3, and we leave it as a last resort. We have various drops that can lower intraocular pressure, and we can also perform something called a laser trabeculoplasty, which has been shown to be as effective as one drop. And it does reduce the burden for patients, so that patients don't have to put in a drop every night because life gets in the way. We do forget. The drops are also sometimes a bit irritating to the eye, and the laser is a good alternative to.
Let me take you through those 3 options for treating glaucoma. We've got eye drops, we've got laser, and we've got surgical options these days. Now, drops are commonly used. I guess they're easy to start off treatment with the aim of reducing the pressure in the eye. But there are problems with drops in the long term, aren't there?
There are. Drops over time, especially if you're going to be on them for 20 or 30 years. Now, some patients tolerate them very well, some patients not so much. The patients that don't, it's because the drops can cause inflammation within the eye, they can cause irritation to the ocular surface, and they can cause quite severe dry eye, and that affects quality of life. As an ophthalmologist, we don't extend quantity of life. Our work is very much related to quality of life. So it's not just how well you can see, but also how well your eyes feel.
Laser trabeculoplasty is one of the techniques you've mentioned for controlling glaucoma pressure. Is that a big commitment? Do you have to go to hospital for that?
No, it's not. Laser is, patients hear the word laser and they get very scared, and they think it means something from a James Bond movie. But it's actually one of the most simple outpatient procedures we have. We do it in the clinic, 1 drop of anaesthetic in the eye, and it's usually done over 1 or 2 sessions. It takes about 5 minutes per eye. We don't cut anything open. What we are doing with the laser is essentially heating up the drainage pathway inside the eye, and that allows for more fluid to exit the eye, thereby bringing down the pressure.
Surgery for glaucoma is an option. It's probably left to the last after drops and laser, but it has its place.
Yeah.
There's the full-on glaucoma operation called a trabeculectomy, but there are some maybe simpler and easier techniques that can be used before committing to a full glaucoma trabeculectomy. What are the alternatives surgically?
So until I'd say 2010, maybe 2015, the trabeculectomy was the gold standard for glaucoma treatment. It was the gold standard because it was one of the only treatments that we had. Since then, we've had a big breakthrough in the field of interventional glaucoma, where we try and fix the glaucoma without the nasty surgery that is a trabeculectomy. These days, we can combine cataract surgery with the insertion of a stent into the eye, whether that be a hydra stent or an eye stent. And this stent sits within the eye. You'll never see it, you'll never feel it. And it can bring the pressure down significantly and get you off multiple eye drops. In addition to that, we have another surgery which is a Zen trabeculectomy. It's a modified trabeculectomy, but it has a lower risk profile in terms of very low pressure compared to the traditional surgeries.
I think patients can often understand glaucoma surgery and the parallels with, say, heart surgery, in that sometimes people need open heart surgery, which is a big operation, and sometimes people can have a stent threaded up into a blocked artery in their heart to overcome heart disease. And glaucoma is very similar to that. There's a very big operation called a trabeculectomy and these stents. Now, I hear that stents can be performed at the time of a cataract procedure. Do you do that often?
Yes. So for my glaucoma patients, almost all of them are given the option of having a stent at the time of cataract surgery. And the results are, we have 5-year data now from the Horizons study, which has shown a significant improvement in quality of life, reduction in the need for topical therapy, and a reduction in pressure with these stents.
So if a person has a cataract and needing cataract surgery, but they are also on glaucoma medication, that medication may not be working adequately, or the chronic side effects of the drops may be an issue, they need to discuss with their eye surgeon the possibility of combining cataract and stenting at the same operation. Does that add much to the time or the complications of cataract surgery?
Look, that's a very good question. And a lot of patients do ask, well, is stenting safe? Combining it with cataract surgery. It is incredibly safe. The biggest issue that we have with it is that sometimes we can have increased bleeding into the eye, which usually resolves within a day or so after the surgery. It doesn't add a significant layer of complexity, especially in experienced hands.
And if a person has a glaucoma stent at the time of cataract surgery, does that stop them being able to keep using other means for glaucoma control if it's necessary in the future?
Yeah, no, not at all. One of the big reasons that we use the stents is not to get patients off all of their drops, but just to reduce the number of drops that they need. There are 4 different types of eye drops on the market, 4 different families for glaucoma control, and they work by different mechanisms. And often we have patients on all 4 families of eye drops, and that can be quite a lot of toxicity to the eye. So by putting a stent in at the time of cataract surgery, if we can get them off 2 or 3 of those eye drops, that can make a big difference to quality of life.
Trabeculectomy can be a very useful operation if the alternative is to be going blind.
Yes.
What would you advise a patient who needs a trabeculectomy about the post-operative course that they will experience?
Yeah, look, trabeculectomy is a much more involved surgery. It's a much bigger surgery. As you said, there is a risk of the pressure going too low, and there is certainly a risk of blindness from the surgery itself. And this is something I talk to all of my patients about. The downtime after trabeculectomy is usually about 4 to 6 weeks. It doesn't mean you're bedbound, but you do have restrictions on what you can do in terms of heavy lifting, in terms of exercise. Some people consider trabeculectomy to be an old-fashioned surgery, but in terms of pressure reduction, it still gives us one of the lowest pressure reductions. And for patients with very advanced glaucoma, often it is the most appropriate choice.